What if I told you that the shape of your fingernail can tell a medical detective that your heart has been quietly failing for years?
Right. Or, that a sudden inability to smell your morning coffee might actually be the very first warning sign of a brain tumor.
It sounds like something out of a mystery novel, honestly. But welcome to the deep dive. I'm your host, and I'm joined by our resident clinical expert.
Hey, everyone. Yeah, it sounds crazy, but that is the reality of clinical assessment. Every single outward physical trait is tied to an internal function.
Exactly. And you, the listener, you've sent us this massive stack of medical surgical texts and HESI nursing assessment guides today.
Oh, yeah, it's quite the sack.
It is. And looking through these, it becomes incredibly clear that the human body isn't just a machine. I mean, it's this interconnected web of quiet, subtle warning lights.
Totally. And our mission today is to decode that secret language. We're going to explore how healthcare professionals use advanced clinical judgment to, read those tiny clues.
Translating them into profound internal truths. Because when you step into the world of adult health assessment, the diagnostic landscape is, well, it's often incredibly murky.
It is the absolute definition of diagnostic muddy waters.
Yeah.
You don't always get a clean binary X-ray showing a broken bone.
Right. It's rarely that simple.
Exactly. Often you're presented with a vague symptom like fatigue or maybe a slight dizziness, and you have to trace that symptom back through, like, miles of neurological and chemical pathways.
Just to find the source. And memorizing that a specific sound in the lungs is, quote, bad, doesn't actually help you if you don't understand the physical mechanism creating that sound.
Yeah, that's a huge HESI exam pitfall, by the way. You have to understand the why and the how. Like, what is the priority finding? What do you assess next? That is clinical judgment.
And to build that clinical judgment, to really read the secret language, you have to start with a baseline. You can't just start poking and prodding someone.
No, definitely not.
The sources are actually incredibly strict about how you gather data before you ever even lay hands on a patient.
Because the environment dictates the quality of your evidence. I mean, think about it from a physiological standpoint.
Okay, lay it on me.
If you, the listener, walk into a freezing cold, glaringly bright clinical room and a practitioner looms over you while you're sitting in a paper gown, what happens?
I mean, I'd be terrified. My sympathetic nervous system immediately fires up.
Right, your adrenal glands release adrenaline, your blood vessels constrict, your heart rate spikes.
And my respiratory rate climbs.
Exactly. So if I take your blood pressure right then, the data is completely skewed. It's not your actual baseline.
Right, you've essentially induced a mild fight-or-flight response just by setting up a hostile environment.
You are measuring the patient's reaction to the room, not their underlying health. This is why the texts emphasize removing physical barriers.
Like desks and things.
Yeah, don't sit behind a desk.
Right.
It creates this weird power dynamic that inhibits honest communication. Sit down, get at eye level.
You're quite literally leveling the playing field to deactivate that sympathetic nervous response, just to get accurate data.
Exactly. And once you've established that safe environment, you start dividing the evidence into two distinct buckets.
Subjective data and objective data. And I feel like people often get confused about which is which, especially with things like pain.
Oh, it's critical distinction.
Yeah.
And it trips up nursing students all the time. Subjective data is the story.
So it's whatever the patient experiences and reports.
Yes. If they say they're nauseous or exhausted or having an 8 out of 10 burning pain in their chest, that is strictly subjective.
Wait, hold on. If they say their pain is an 8 out of 10, aren't they giving you a number? Doesn't a number make it objective?
It's a great question, but no. We use pain scales to try to track the subjective experience over time, but the pain itself...
Can't be verified.
Right. It cannot be independently verified or measured by an outside observer. The experience belongs entirely to the patient.
So we must believe the witness.
Always. Objective data, on the other hand, is the forensic evidence at the crime scene. It's what the clinician can directly observe, measure, or test.
Okay, so the subjective data is, my chest hurts, and the objective data is the heart rate of 120 beats per minute.
Exactly. Or the diaphoresis, the sweating on their forehead, or the elevated troponin levels on their blood test.
Got it. And clinicians organize this using the SOAP note framework, right? SOAP.
Yep. Subjective, what the patient says. Objective, what you measure. Assessment, your clinical judgment combining the two. And plan, what you're going to do about it.
To gather that objective data, the texts outline 4 primary physical assessment techniques, and they almost always happen in a very specific chronological order.
Inspection, palpation, percussion, and auscultation. IPPA.
Let's break down the nuance here, because it's not just looking and touching, is it?
Far from it. Inspection begins the absolute second you lay eyes on the patient.
Yeah.
You're assessing their gait, their posture, their skin color.
And even smelling them, right? The texts mention that.
Oh, absolutely. For instance, a fruity acetone smell on the breath is a massive red flag for diabetic ketoacidosis. That's a priority finding before you've even said hello.
Wow. Then comes palpation, which is feeling the body. But the sources are very specific about how to touch.
Yes, the technique matters immensely.
Like if I want to check a patient's temperature, why do the texts insist I use the back of my hand, the dorsal surface, rather than my palm or fingertips? My fingertips are way more sensitive.
Well, your fingertips are highly sensitive to tactile discrimination, sure, like texture, shape, and moisture.
Cause of all the nerve endings?
Right, because they have a high density of Meissner's corpuscles.
Oh.
But they are not the best for temperature.
Oh, really?
Yeah, the skin on the back of your hand is much thinner. That means the thermoreceptors there are closer to the surface, making it far more accurate at detecting subtle changes in a patient's skin heat.
That makes perfect sense. You're just using the right sensor for the right job.
Exactly. And after touching, we move to percussion, tapping on the body.
You strike the patient's body with short, sharp strokes, usually tapping your own middle finger against their skin, right?
Yeah, you're essentially using acoustic impedance to figure out what's underneath. Sound waves travel differently through air, fluid, and solid mass.
So if I'm percussing over a healthy lung, which is essentially like a giant sponge full of air, what should that sound like?
It should sound resonant. A low-pitched, clear, hollow sound.
But what if they're sick?
Well, if that lung is filled with fluid from pneumonia, the sound wave hits that dense fluid and stops. The sound becomes dull or muffled.
And what about the opposite, like too much air?
Good question. If a patient has severe emphysema and air is trapped in the lungs, hyperinflating them, the sound becomes hyperresonant, almost like a booming bass drum.
Wow. And finally, we have auscultation, listening with a stethoscope to the heart, lungs, and bowels.
Right, gathering that auditory objective data.
But I want to pause on the interview process for a moment before we dive into the specific organ systems.
Okay, sure.
Because the subjective data gathering goes so much deeper than just asking, where does it hurt? The texts discuss evaluating functional health patterns.
Oh, yes. Gordon's functional health patterns.
Right. Asking about a patient's coping mechanisms or their sleep rest pattern. If someone comes in complaining of an itchy rash, why are we interrogating their sleep schedule?
Because of the systemic cascade effect. Everything is linked. Let's trace it. Say a patient has intense pruritus or itching.
Okay, that's the initial symptom.
Right. But that itching keeps them awake all night. Chronic sleep deprivation elevates cortisol, stresses the cardiovascular system, and leads to severe fatigue.
And when they're fatigued?
That fatigue means they stop exercising. The lack of movement slows down their gastrointestinal transit time, leading to severe constipation.
So a skin issue has literally caused a bowel issue, simply through the mechanism of sleep deprivation. That's wild.
Exactly. Or look at the coping stress tolerance pattern. A patient reports they are suddenly unable to handle minor daily stressors. They're having panic attacks.
And novice might just say, oh, they have anxiety.
But advanced clinical judgment asks why. The body's stress response is hormonally driven by the adrenal glands.
So it might be physical.
Yes. If a patient suddenly can't cope, it might not be a psychological issue at all. It might be adrenal insufficiency. Their endocrine system is failing to produce the cortisol needed to manage physiological stress.
The behavioral symptom is a direct clue to an organ failure. It's all connected.
It really is.
Okay, so we have our tools, we understand the environment, and we know how to categorize our evidence. Where does a clinician actually start the physical exam?
Well, it seems like you have to start with the system that governs everything else, right? You start with the command center.
The neurological system and the sensory organs.
Because if the nervous system isn't interpreting the world correctly, everything else you assess is going to be filtered through a broken lens.
We evaluate the cerebral cortex first through mental status, and the texts break this down into assessing appearance, behavior, cognition, and thought processes.
The ABCTs of mental status.
Right. Like, are they dressed for a blizzard when it's 90 degrees outside? Do they know who they are, where they are, and the current date?
Yes, assessing orientation to person, place, and time. But when a patient has altered consciousness, say they've had a head trauma or a massive stroke, subjective descriptions are dangerous.
Like calling someone lethargic.
Exactly. My definition of lethargic or stuporous might be completely different from yours.
Which is why the texts hammer on the Glasgow Coma Scale, the GCS. It forces the clinician to be completely objective.
It's a huge HESI priority. It removes the subjectivity.
But how does it actually work? It's a 15-point scale, right?
Correct. 15 is a perfect score, representing a fully alert, responsive patient. 3 is the lowest possible score, representing deep coma or death.
And what are we actually measuring?
The genius of the GCS is that it breaks brain function into 3 distinct observable motor pathways: eye-opening, verbal response, and motor response.
So for eyes, it's a 4-point scale. If you walk in and they're looking at you naturally, that's a 4.
Right. And if you have to yell their name to get them to open their eyes, that's a 3.
And if you have to physically inflict a painful stimulus, like a sternal rub, to get an eye flutter, that's a 2. And if nothing happens, it's a 1.
Exactly. Then verbal is a 5-point scale. Are they conversing normally, or are they just moaning incomprehensible sounds?
And motor is a 6-point scale, which the texts say is the most critical for identifying the location of brain damage.
It is. Do they obey commands?
Mm.
If you inflict pain, do they try to push your hand away, which is localized, purposeful movement? Or do their arms rigidly curl inward toward their chest?
Oh, that rigid curling, the texts call that decorticate posturing, right?
Yes, decorticate posturing indicates severe damage to the cerebral hemispheres or the internal capsule. It's a massive red flag.
So the GCS really does remove the guesswork.
Totally. If a patient was a 14 an hour ago and is now a 9, you don't need to debate if they look more tired. You know definitively that their intracranial pressure is rising, and it's a medical emergency.
Wow. Moving from the brain itself to the wiring that connects it to the face and senses, we have the cranial nerves.
12 pairs of nerves that emerge directly from the brainstem rather than the spinal cord.
I was reading about cranial nerve, the olfactory nerve. You have the patient close their eyes, block one nostril, and try to identify a smell, like coffee.
Yep, a classic test.
If they can't smell it, why is that such a big deal? Isn't it usually just a sinus issue?
I mean, it could be, but you have to look at the anatomy. The olfactory bulb sits directly under the frontal lobe of the brain.
Okay.
If a patient suddenly loses their sense of smell anosmia, and it isn't a viral sinus infection, it strongly suggests a frontal lobe lesion.
Like a tumor.
Perhaps a meningioma, yeah, physically pressing down on the olfactory tract, crushing the nerve.
So a loss of smell is actually a space-occupying lesion in the skull. That is terrifying.
It highlights why we check it. And then there's the eyes. Cranial nerves 2, 3, 4, and 6 all deal with vision and eye movement.
The texts use the acronym PERLA endlessly.
Because it evaluates a critical neurological loop. PERLA stands for pupils equal, round, reactive to light, and accommodation.
Let's look at the reactive to light part.
Okay, so when you shine a pen light into a patient's right eye, the optic nerve, cranial nerve 2, carries that light signal back to the midbrain.
And then what?
The midbrain then sends a signal back out through the oculomotor nerve, cranial nerve 3rd, telling the pupil's sphincter muscle to constrict.
So the signal goes in through nerve 2 and comes out through nerve 3rd.
Yes. And because the midbrain connects both sides, shining a light in the right eye should cause both the right and left pupils to constrict simultaneously.
That's the direct and consensual reflex.
You got it.
Okay, so what if I shine a light in the right eye and the right pupil shrinks, but the left pupil just stays wide open, totally blown?
That is one of the most terrifying findings in a clinical assessment. A blown pupil means the oculomotor nerve on that side is being crushed.
Crushed by what?
Well, because the skull is a rigid, closed box, if the brain starts to swell, say, from a hemorrhage, it has nowhere to go but down through the hole at the base of the skull. Yeah. As it shifts downward, it compresses cranial nerve 3. A unilaterally blown pupil often means brain herniation is imminent. It is the ultimate priority finding.
Okay, so the nervous system is the wiring, and the senses are the security cameras. Let's talk about the audio cameras. The ears.
Moving on to cranial nerve 8.
Right. The texts mention the Weber and Rinn tests using a tuning fork. Why are we placing a vibrating piece of metal on someone's skull?
We're testing the physics of sound conduction to differentiate the type of hearing loss. Sound can travel through the air in your ear canal, but it can also travel directly through the solid bone of your skull to the inner ear.
So the Weber test involves striking a tuning fork and placing it dead center on the top of the patient's head.
Exactly.
And normally you should hear the sound equally in both ears.
Right. But if you have a mechanical blockage in your right ear, say it's packed with earwax, or you have a middle ear infection full of fluid, that is conductive hearing loss.
Okay.
Interestingly, the sound from the tuning fork will actually lateralize or seem louder in the bad ear.
Wait, why would it be louder in the ear that's blocked? That feels backwards.
It does, right? But it's because the blockage in the ear canal prevents the ambient background noise of the room from getting in. The inner ear on that side is isolated, so it picks up the bone-conducted vibration from the tuning fork much more acutely.
Oh, that makes sense. And what about the other type of hearing loss?
Conversely, if the nerve itself is dead on the right side, sensorineural hearing loss, the sound will lateralize to the good left ear because the right ear simply cannot process the signal at all.
That is brilliant physical engineering. While we're in the inner ear, we have to talk about balance. The texts make a huge deal about differentiating dizziness from vertigo.
Which is another classic SSI topic.
I think colloquially, we just use those words interchangeably.
We do, but clinically they point to completely different pathologies. Dizziness is a feeling of being lightheaded, faint, or woozy.
Like when you stand up too quickly.
Exactly. It's almost always cardiovascular. It means not enough oxygenated blood is reaching the brain.
But vertigo is different.
Vertigo is the distinct illusion of movement. The patient feels like the room is physically spinning around them, or they are violently spinning in a stationary room.
So it's not a blood flow issue.
No, that is a sensory processing error.
Yeah.
It's almost exclusively a problem with the vestibular system in the inner ear, the semicircular canals that detect head rotation, or a neurological problem in the cerebellum or brainstem.
Which perfectly sets up this test that fascinated me. The Romberg test.
Ah, yes. Assessing equilibrium.
You ask a patient to stand with their feet together and their arms at their sides.
Yeah.
Now, maintaining human balance requires 3 inputs, right?
Yep. Vision, vestibular function in the ear, and proprioception.
Proprioception, which is the muscles and joints telling the brain where the body is in space.
Exactly. You need at least 2 of those 3 working perfectly to stay upright. So in the Romberg test, you first have them stand with their eyes open.
And if they fail that?
If they're swaying wildly or falling over with their eyes open, their cerebellum, the part of the brain coordinating motor movement, is likely damaged.
But if they are perfectly steady with their eyes open, you ask them to close their eyes. What happens then?
By asking them to close their eyes, you're intentionally eliminating one of the 3 inputs. You're turning off the visual backup generator.
So now they only have 2 inputs left.
Right. Now, they must rely solely on their inner ear and their joint proprioception. If they immediately sway and lose their balance, a positive Romberg sign, it tells you definitively that either their vestibular system or their sensory spinal tracts are severely damaged.
Because they were relying entirely on their eyesight to compensate for the broken systems.
You're systematically isolating the sensory inputs to find the broken wire.
And speaking of broken wires, there's one more sensory test that blew my mind. Testing for extinction.
Oh, this one is fascinating.
Explain how extinction works, because it honestly sounds like a magic trick.
It does, but it's a profound window into cortical mapping. You have the patient close their eyes. You touch them on identical points on both sides of their body simultaneously. Say you tap both of their kneecaps at the exact same time.
Normally, a person feels both taps.
But in a patient with a lesion in the parietal cortex of the brain, often from a stroke, they will only perceive the tap on the side of the body controlled by the healthy hemisphere.
So if the right parietal lobe is damaged, they only feel the tap on the right knee, cause the left parietal lobe processed it.
Correct. The nerve in the left knee works perfectly. The spinal cord works perfectly. The signal reaches the damaged right parietal lobe, but the brain simply drops it.
It extinguishes the stimulus.
Yes, because it cannot process simultaneous bilateral information. The signal reaches the command center, but the receptionist just throws it in the trash.
It's not a nerve failure, it's a processing failure. Okay, so we've mapped the command center, the brain, and the senses.
But this highly complex electrical grid is totally useless without power. We have to move to the organs that deliver the fuel.
The engine room. The cardiovascular and respiratory systems.
And this is where the critical thinking of a clinician is tested daily, because you have to understand the difference between the physical mechanics of the chest and the invisible chemistry of the blood.
Right. Let's start with respiration. The texts draw a hard line between ventilation and oxygenation.
Yes, HESI loves this distinction.
If a patient is breathing 30 times a minute, they're ventilating perfectly, so why might they still be turning blue?
Because ventilation is just moving the box to the warehouse. Oxygenation is unpacking the box.
Okay, I love that analogy. Break it down.
Ventilation is strictly mechanical. It relies on intrathoracic pressure. When your diaphragm contracts, it pulls downward, increasing the volume of your chest cavity.
And according to Boyle's law, as volume increases, pressure decreases.
Right. The pressure inside your lungs drops below the atmospheric pressure outside, and air physically rushes in to equalize it.
Like a bellows pulling air into a fireplace.
Exactly. But oxygenation is chemical diffusion. It occurs at the microscopic level in the alveoli, the tiny air sacs in the lungs. Oxygen must diffuse across the very thin alveolar capillary membrane into the bloodstream, binding to hemoglobin.
So what disrupts that?
Well, if a patient has severe pneumonia, those alveoli are filled with pus and fluid.
The warehouse is flooded.
Yes. They can pump the bellows 30 times a minute, pulling plenty of air into the lungs. Excellent ventilation. But the oxygen physically cannot cross through that fluid barrier into the blood.
Oxygenation fails.
The tissues starve, and the patient turns cyanotic or blue.
This mechanical failure is also why we inspect the shape of the chest. The texts talk about the barrel chest in patients with chronic obstructive pulmonary disease, or COPD.
A very common, visually distinct finding.
I've seen this. The patient's chest looks literally puffed out all the time. Why does a lack of oxygen permanently reshape the human rib cage?
It's a structural adaptation to chronic air trapping. COPD, specifically emphysema, destroys the elastin in the lung tissue. The lungs lose their rubber band-like recoil.
So they don't snap back.
Right. When a healthy person exhales, the lungs naturally snap back, pushing the air out. But in COPD, the lungs become baggy. Air goes in, but it can't be pushed fully out.
So they were constantly holding on to stale air.
Year after year. This chronic hyperinflation flattens the diaphragm downward and pushes the rib cage outward. A normal chest has an antero-posterior front-to-back diameter that is about half the width of the side-to-side diameter, a 1:2 ratio.
But over years of air trapping,
The front-to-back diameter expands until it is equal to the side-to-side width, a 1:1 ratio. The chest literally becomes a barrel just to accommodate the trapped air.
it's a permanent mechanical deformation. Wow. And then we pull out the stethoscope to listen to the airflow.
Auscultation.
Yes, and the texts get very specific about adventitious or abnormal lung sounds. Crackles versus wheezes.
Understanding the physics of these sounds tells you exactly what is going wrong inside, right? Absolutely.
Yeah.
Normal vesicular breath sound like wind rustling through leaves. But if you hear crackles, a popping, bubbling sound, especially when the patient inhales, you're hearing fluid dynamics.
Like blowing air through a straw into a glass of water.
Precisely. It means fluid is accumulated in the tiny airways, usually from heart failure or pneumonia. The popping sound is the small airways bursting open through the fluid as air rushes in.
Okay, and what about wheezes?
Wheezes, on the other hand, are high-pitched musical squeaks. They indicate that the airway itself has narrowed severely, either due to a spasm like in an asthma attack or severe inflammation.
So you're forcing air through a tight pipe, creating a whistle.
Yes. So you hear crackles, you think fluid. If you hear wheezes, you think constriction.
That covers the air. What about the blood, the other half of the engine room?
Cardiovascular assessment revolves around one ultimate goal: perfusion. Is oxygenated blood physically reaching the tissues?
We start with the most basic metric, blood pressure. But the text highlights a highly specific calculation called MAP, or mean arterial pressure.
Very important concept.
Right. It states that the MAP must be greater than 60 millimeters of mercury to perfuse vital organs. Why is this average number more important than the standard 120/80 we always hear about?
Because blood pressure is pulsatile. It's not a flat flow. The top number, systolic, is the peak force when the left ventricle violently squeezes blood out.
And the bottom number, diastolic, is the resting pressure in the vessels when the heart refills.
But the organs don't just need a quick blast of blood, they need continuous flow.
So the MAP is the average pressure pushing that blood through the capillary beds over the entire cardiac cycle.
Yes. And physics dictates that if that average pressure drops below 60 millimeters of mercury, there is simply not enough hydrostatic force to push blood into the microscopic, high-resistance capillary beds.
Like in the kidneys or the brain.
Exactly. Or the coronary arteries of the heart itself. The organs will instantly begin to starve, leading to ischemia and necrosis. Below a MAP of 60, the patient is in shock, regardless of what their systolic number is.
To ensure the pump is actually generating that pressure, we auscultate the heart sounds, the classic S1 and S2, the lub-dub.
S1, the lub, is the sound of the mitral and tricuspid valves snapping shut as the ventricles contract. S2, the dub, is the aortic and pulmonic valves snapping shut after the blood is ejected,
But clinicians are listening for the spaces in between, aren't they? They're listening for murmurs.
which are graded on a scale of 1 to 6.
And what actually causes a murmur?
A murmur is the sound of turbulent blood flow. Normally, blood flows smoothly, silently, but if a valve is stenotic, meaning it's stiff and narrowed, the heart has to force blood through a tiny opening, creating a whooshing sound.
Like putting your thumb over a garden hose.
Exactly. Or, if a valve is incompetent and doesn't close all the way, blood violently regurgitates backward when the heart squeezes. That turbulence is a murmur, and grading its volume and timing tells you exactly which valve is failing.
Now, here is where the clinical assessment crosses over from the physical exam into high-tech, deep-level data. The texts mention hemodynamic monitoring.
Using invasive catheters placed directly into the major arteries and the heart itself.
It sounds like plugging a high-end sports car into a diagnostic computer.
It is the ultimate objective data collection, and it's used in the ICU for the sickest patients. We use arterial lines for continuous second-by-second blood pressure monitoring.
And what about the heart itself?
We use pulmonary artery catheters, which are threaded through the right side of the heart and into the lungs to measure the exact pressures inside the heart chambers.
But the metric that really caught my eye in the texts was SCVO2 or SVO2, mixed venous oxygen saturation.
Oh, this is a brilliant metric.
Let's do a deep dive here. Why on earth do we care about the oxygen levels in the veins? Don't the arteries carry the oxygen to the body?
This is one of the most amazing pieces of clinical physiology you will ever learn. Yes, the arteries deliver the oxygen. Normal arterial saturation, SaO2, is 95 to 100%.
Right.
The oxygenated blood travels to the capillary beds, the tissues extract exactly what they need to survive, and the deoxygenated blood returns to the right side of the heart via the veins.
Okay, but it's not totally empty, right?
Exactly. Normal venous oxygen saturation, the SVO2, is actually around 60 to 80%.
Wait, so the tissues normally only extract about 20 to 30% of the oxygen delivered to them? They leave a massive reserve in the blood.
Right. Think of the blood as a fleet of delivery trucks, leaving the pulmonary warehouse 100% full of oxygen boxes. They drive through the city, the body make their standard deliveries, and return to the warehouse 75% full.
But what if we measure the returning trucks, the SVO2, and they are only like 40% full? What does that mathematical drop tell us?
It means one of two things must be happening. Either the trucks left the warehouse half empty to begin with because the lungs aren't working.
Or the factories out in the city are working in massive overdrive and pulling way more boxes off the trucks than normal.
You've just perfectly described oxygen supply and demand.
Mm-hmm.
A significant drop in SVO2 is the earliest warning siren of impending shock. If the heart is failing and not pumping enough blood, a low cardiac output, the blood moves sluggishly past the tissues. The tissues are starving, so they extract every single molecule of oxygen they can from that slow-moving blood. The blood returns to the heart completely depleted.
Or if the patient has a massive infection sepsis or a high fever, their metabolic rate skyrockets.
Yes, they're burning fuel so fast that they consume the oxygen faster than a healthy heart and lungs can deliver it.
So the SVO2 tells the clinician in real time that the patient's oxygen demand is vastly outstripping their delivery.
It allows the nurse or doctor to intervene by giving fluids, blood, or heart-stimulating drugs long before the patient's blood pressure drops or their organs fail.
That is incredible. Now, placing these invasive lines is obviously risky. The texts mention a specific safety check that must be done before inserting an arterial line into the radial artery in a patient's wrist.
Oh, the Allen test, a huge safety priority.
Right. You physically compress the arteries in their wrist and watch their hand change color. Why is this so crucial?
It's a vital assessment of collateral circulation. The hand is supplied by two main arteries, the radial artery on the thumb side and the ulnar artery on the pinky side.
And they join together in the hand to form a vascular arch, right?
Yes. When you insert a thick plastic catheter into the radial artery, you risk aggravating the vessel and causing a thrombus, a clot, that completely occludes it.
Which would kill the blood supply to that half of the hand?
Unless the ulnar artery is healthy enough to take over and supply the entire hand via that arch. So the Allen test simulates the clot.
How do you do it?
You use your thumbs to tightly compress both the radial and ulnar arteries simultaneously. The patient opens and closes their fist several times until the blood is pumped out and the hand turns stark white, blanched. Then you release only the ulnar artery.
While keeping the radial artery pinched shut.
Yes. You watch the palm. If the hand flushes pink again within about 6 seconds, it means the ulnar artery is patent and robust enough to perfuse the hand all by itself.
So it's safe to use the radial artery for the line.
But if the hand stays pale and white, they fail the Allen test. The ulnar artery is inadequate. You absolutely cannot put a line in that wrist, or you risk the patient losing their fingers to gangrene.
The stakes of these simple physical checks are so incredibly high. Another wild example of this is the carotid brute. You just place a stethoscope on the side of a patient's neck.
Normally, you shouldn't hear anything over the carotid artery except maybe the faint transmission of normal heart sounds. But if you hear a brute, a distinct blowing, swishing, humming sound, it means blood is being forced through a severely narrowed pipe.
Plaque buildup, atherosclerosis.
Yes. The artery is choked with cholesterol plaque. The swishing sound is the turbulence of the blood fighting its way through. And it is a massive red flag because it indicates a high risk that a piece of that fragile plaque could break off, travel a few inches north directly into the brain, and cause an ischemic stroke.
A quiet humming in the neck tells you a stroke is looming.
Okay, so the engine is pumping oxygenated blood at the perfect MAP. Where does it go? Which brings us to the systems that actually use the fuel. Processing plant.
The gastrointestinal, urinary, and endocrine systems. Once the blood is oxygenated, it fuels the internal factories that process our food, filter our waste, and regulate our chemical messengers.
And right out of the gate, when we assess the abdomen, the gastrointestinal system, we hit a massive exception to our physical assessment rules.
Right, I was going to bring this up. We established the golden rule of assessment is IPPA, inspect, palpate, persist, auscultate.
Yes.
But for the abdomen, the text explicitly says we inspect, auscultate, percuss, and then palpate. Why do we completely alter the chronological order and listen before we touch?
Because you don't want to contaminate the crime scene before you take the photos. The gastrointestinal tract is lined with smooth muscle and stretch receptors. It is incredibly sensitive to physical stimulation.
So if you push on the stomach, if you palpate it deeply to feel for masses, you physically massage the intestines.
And that massage wakes them up. It triggers peristalsis, the muscular wave that moves food through the gut.
Oh, I see.
If you palpate first and then put your stethoscope on the belly, you might hear hyperactive gurgling and think, great, their GI tract is functioning beautifully. But those sounds were entirely artificial, caused by your hands.
So they might actually have a paralytic ileus. Their bowel might be totally paralyzed from surgery or trauma, and you just tricked yourself into thinking they were fine.
Exactly. You have to listen before you touch to hear what the bowel is doing naturally on its own. We listen for normal borborygmi, which are high-pitched gurgling sounds occurring every 5 to 15 seconds.
And what if you hear nothing?
If we listen for a full 5 minutes in each quadrant and hear absolute silence, that is a medical emergency indicating a bowel obstruction, perforation, or paralysis.
Then we move to the urinary system, the body's filtration plant.
We palpate the lower abdomen for the bladder. A normal empty bladder sits deep in the pelvis and isn't palpable.
But if it's full?
If you can feel it bulging up toward the umbilicus, it is distended with trapped urine, indicating retention. We also assess the kidneys directly via CVA tenderness.
The costovertebral angle. That's on the back, right where the lowest ribs meet the spine.
Yes. You place one hand flat over that angle and strike the back of your hand with your other fist. It shouldn't hurt.
But if it does...
If the patient jolts forward in deep, sharp pain, it's a classic sign of kidney inflammation, often pyelonephritis, a severe ascending kidney infection.
But the physical exam can only tell you so much about a filter. You have to look at what the filter is actually producing, Ro.
You need the lab values.
The texts talk endlessly about monitoring BUN and creatinine levels in the blood. What exactly are these molecules, and how do they tell us if the kidney is failing?
Let's break it down. BUN stands for blood urea nitrogen. When your body breaks down proteins, it produces ammonia, which is toxic. Your liver converts that ammonia into urea, which is then dumped into the blood for the kidneys to filter out into the urine.
And what about creatinine?
Creatinine is a waste product generated constantly by normal muscle metabolism.
So both of these are waste products that should be constantly flushed down the toilet by the kidneys.
Precisely. The kidneys maintain a very specific glomerular filtration rate, or GFR. If the kidneys are damaged, perhaps by chronic high blood pressure, diabetes, or nephrotoxic drugs like heavy antibiotics or ibuprofen, the filters clog up.
The GFR drops.
Because the kidneys can't excrete the waste, the levels of BUN and creatinine in the blood begin to rapidly rise.
So high blood numbers mean low kidney function.
Exactly. And creatinine is the most reliable indicator because its production by the muscles is incredibly steady. If blood creatinine doubles, it generally means kidney function has fallen by 50%.
That makes the math very clear. And then there's the endocrine system. I have to say, reading through this section, it's felt like reading about the body's Wi-Fi network.
Oh, I like that comparison.
Yeah, it's totally invisible to the naked eye, but when the router goes down, every device in the house stops working.
That is a great starting analogy, but let's evolve it further. The endocrine system isn't just sending a generic Wi-Fi signal. It's sending highly encrypted data packets, hormones, through the bloodstream.
Okay, encrypted data packets.
And those packets can only be opened by specific devices, target cells, that have the exact matching decryption key or receptor.
Oh, that's perfect. So the master regulators, the hypothalamus, the pituitary, the thyroid, the adrenals, the pancreas, they are the servers dispatching these encrypted packets.
Yes, and because they're deep inside the body, aside from the thyroid gland in the neck and the testes, you cannot physically palpate or percuss the endocrine system. You cannot hear it with a stethoscope.
So how on earth do you assess a system you can't see, hear, or feel?
You assess the target cells. You look at how the devices on the network are behaving. Endocrine dysfunction always manifests systemically.
Can you give an example?
Take the thyroid gland. It regulates basal metabolic rate. If the thyroid is underactive, hypothyroidism, it's like turning down the power supply to the entire body. The patient presents with cold intolerance, unexplainable weight gain, severe fatigue, a slowed heart rate, and their skin becomes thick and dry because cellular turnover has plummeted.
But if it's overactive hyperthyroidism, the power is surging.
Exactly. They have heat intolerance, rapid weight loss despite eating constantly, a racing heart, tremors, and a classic sign called exophthalmos, where the tissues behind the eyes swell and push the eyeballs forward, making them bulge.
The texts also dive into the adrenal glands, which sit right on top of the kidneys. They produce cortisol, the stress hormone, and aldosterone, which regulates blood pressure.
And diseases of the adrenals create incredibly specific physical changes. In Addison's disease, the adrenal glands fail and stop producing cortisol and aldosterone.
So the body just loses its stress response.
Yes, and the patient experiences profound weakness, dangerously low blood pressure, and a classic hallmark, hyperpigmentation. A deep bronzing of the skin, especially in the creases of the hands, over the joints, and even on the gums.
Why does their skin turn bronze?
It's caused by the pituitary overproducing melanocyte-stimulating hormone as it desperately tries to wake up the dead adrenal glands.
And the opposite is Cushing's syndrome, right? Too much cortisol.
Yes. Cortisol heavily influences fat metabolism and vascular tone. In Cushing's, the excessive cortisol causes the body to abnormally redistribute fat to the central core.
How does that look on the patient?
The patient develops a very round moon face, a fat pad on the back of the neck called a buffalo hump, and their skin becomes so fragile that they develop deep purple stretch marks, or striae, on their abdomen.
So the detective has to piece together these seemingly random clues, a chubby face, purple marks on the belly, and incredibly thin arms and legs, and realize the problem isn't their diet, it's a tiny gland sitting on top of the kidney firing out too many encrypted packets.
And it gets even more nuanced when we look at the parathyroid glands. There are 4 of these tiny lentil-sized glands sitting on the back of the thyroid, and their sole job is to regulate calcium levels in the blood.
Which doesn't sound that important until you realize calcium does way more than just build strong bones.
Calcium is the biochemical key that stabilizes nerve cell membranes and regulates muscle contraction. Without enough calcium in the blood, the threshold for a nerve to fire an action potential drops dramatically.
The nerves become wildly hyperexcitable.
Exactly. If the parathyroid glands are accidentally damaged or removed during thyroid surgery, blood calcium levels plummet, hypocalcemia.
How does a clinician test for that without waiting for a blood lab result?
You test the electrical stability of the facial nerve. It's called the Chvostek sign. You simply tap the patient's cheek right in front of the earlobe over the facial nerve.
And what happens?
If their calcium is normal, nothing happens. But if they're hypocalcemic, that tiny physical tap triggers an action potential, and the muscles on that side of the face will involuntarily spasm and twitch.
You tap the cheek to check the electrical stability of a nerve, which tells you that a gland in the neck is failing to regulate a mineral in the blood. That is the absolute definition of a holistic, interconnected assessment.
It's amazing, isn't it?
Truly. Okay, so we have the command center, the engine room, and the processing plant. But all of these internal organs require a highly active protective barrier and a sturdy frame to move them around.
Which brings us to the framework and the outer armor, the musculoskeletal, integumentary, and hematologic systems.
Let's start with the chassis, the musculoskeletal system, assessing posture, Gait and mobility. We inspect the spine for abnormal curvatures.
Right. Lordosis is an extreme inward curve of the lower lumbar back. Kyphosis is a hunchback curve of the upper thoracic spine, very common in osteoporosis. And scoliosis is a lateral S-shaped curve.
We also rigorously test range of motion, or ROM, and grade muscle strength on a 0 to 5 scale.
Yes, 5 out of 5 is normal strength against full resistance. 0 is total paralysis, no muscle contraction at all. But the clinical judgment here comes from differentiating the source of a mobility problem.
How do you do that?
We assess both active ROM, where the patient moves the joint themselves, and passive ROM, where the patient relaxes completely and the examiner moves the joint for them.
Why do both? I mean, if I can't move my arm, I can't move my arm.
But why can't you move it? If a patient's active ROM is severely limited and painful, but when you do passive ROM, the joint moves perfectly smoothly with full extension, the problem isn't the joint itself.
Oh, it's the muscle.
Exactly. It's the muscle or the tendon trying to pull the joint. But if both active and passive ROM are equally limited and stiff, you know the pathology lies within the joint capsule itself, like severe osteoarthritis or a frozen shoulder.
It's just mechanical troubleshooting. Now, wrapping all of this is the outer armor, the integumentary system, the skin, nails, and hair. I think we usually think of the skin as just a wrapper keeping everything inside.
But reading these texts, it's clear the skin is actually an early warning radar system for the internal organs.
The skin is the largest organ in the body, right? And it is an absolute billboard for the state of the engine room. We talked about using the back of the hand for temperature.
Yes. Hot, erythematous skin means localized inflammation or systemic fever. Cool, clammy skin means the sympathetic nervous system has clamped down on peripheral blood vessels to shunt blood to the core, a classic sign of shock.
We also check turgor, right?
Yeah.
Pinching a fold of skin on the collarbone to see how quickly it snaps back.
Yeah. Normal skin snaps back immediately due to interstitial fluid and elasticity. If you pinch the skin and it tenses up, staying in a pinched ridge for several seconds, it tells you the patient's interstitial spaces are bone dry. They're severely dehydrated.
And color changes are massive clues. Cyanosis, pallor.
Cyanosis is a bluish tinge indicating a severe lack of oxygenated hemoglobin. But the location matters.
How so?
Central cyanosis blueness in the lips, tongue, and oral mucosa means the blood leaving the heart is already desaturated. That is a massive respiratory failure.
And peripheral cyanosis.
That's blue fingers and toes. It means the heart just isn't pumping hard enough to push the blood out to the extremities, allowing the tissues to extract all the oxygen out of the sluggish flow.
Pallor, or paleness, is a classic sign of anemia, right? Not enough red blood cells.
Correct.
But the most fascinating physical adaptation to me was in the fingernails. The texts detail nail clubbing. Can you explain the pathophysiology here? Because looking at my own fingernails right now, I don't understand how a lung problem changes the shape of keratin on my fingers.
It is a remarkable, if slightly flawed, compensatory mechanism by the body. Normally, the angle between the base of your fingernail and the skin of your finger is about 160 degrees. It has a slight downward slope.
Okay, I see that.
But in a patient with chronic, prolonged hypoxia, years of oxygen deficiency from cystic fibrosis, severe COPD, or congenital heart defects, the body panics. It knows the tissues are starving.
So what does it do?
It tries to build new supply lines. It releases massive amounts of growth factors, specifically vascular endothelial growth factor, or VEGF.
And what does VEGF do?
VEGF travels through the blood and stimulates angiogenesis, the creation of new dilated blood vessels in the peripheral tissues trying to capture more oxygen.
And the tips of the fingers are the absolute furthest periphery.
Exactly. These capillary beds in the fingertips massively dilate, and the soft connective tissue under the nail proliferates and swells.
Wow.
The result is that the nail bed puffs up, the normal 160-degree angle flattens out to 180 degrees or more, and the fingertip becomes enlarged and bulbous, looking like a drumstick or a club.
That purely visual clue on a fingernail tells the clinician that the patient has been fighting a losing battle for oxygen for years.
The body literally reshapes its extremities to survive.
Speaking of trainee visual clues, the texts group hematologic, or blood, assessment heavily with the skin assessment, which leads me to this question. If a patient has petechiae, which are those tiny pinpoint red dots on the skin, why does a hematology chapter care about what looks like a minor skin rash?
Because petechiae are not a skin issue. They are a profound bleeding issue manifesting on the canvas of the skin. Petechiae are 1 to 2 millimeter microhemorrhages.
How do they happen?
They happen when the tiny microscopic capillaries in the skin burst under normal hydrostatic pressure.
Wait, our capillaries burst under normal pressure?
All the time. just from walking, sitting, or bumping into things.
Yeah.
But in a healthy person, platelets, the sticky, fragmented cells in our blood that form the primary plug for clots, instantly rush to the microtear and patch it up before a single drop of blood escapes into the tissue.
So we never see it happen.
Right.
So if a patient is suddenly covered in petechia?
It means their platelets are gone. They have severe thrombocytopenia. The tiny holes in the plumbing are bursting, and there's no spagle left in the blood to patch them. Blood is leaking into the skin.
That sounds like a huge red flag.
It is a critical priority finding, because if their capillaries are bleeding unpatched in their skin, they are also bleeding unpatched in their intestines, their lungs, and their brain. A catastrophic internal hemorrhage could happen at any second.
The detective sees a rash and realizes the internal clotting factory has completely shut down. We also assess lymph nodes during this phase, feeling the neck, armpits, and groin.
Yes, the lymphatic system drains cellular waste and houses immune cells. Normal lymph nodes shouldn't be easily palpable. If you feel in a large node that is soft, mobile, and exquisitely tender to the touch, it usually indicates a localized infection. The immune cells are actively fighting a battle there.
But what if it isn't tender?
If you palpate an enlarged lymph node, and it is rock hard, totally painless, and fixed in place, meaning you can't wiggle it around under the skin, that is highly suspicious for a malignancy, like lymphoma or metastatic cancer. Cancer cells have infiltrated the node, multiplied, and anchored it to the surrounding tissue.
Okay, so we've mapped the systems, we have the baseline, but the human chassis isn't static. It changes dramatically over time.
Which brings us to the life cycle, reproductive health and gerontologic changes.
The body goes through massive operational shifts during reproduction and naturally degrades and alters as it ages.
Let's examine the reproductive system, which is entirely governed by one of the most complex hormonal feedback loops in biology, the hypothalamic pituitary gonadal axis, or HPG axis.
I tried to diagram this from the text, and it is a beautiful, confusing mess of chemical arrows. Can we trace the path?
We can. It starts in the brain. The hypothalamus releases a hormone called GnRH, gonadotropin-releasing hormone.
Okay, so from the hypothalamus.
This travels a microscopic distance to the anterior pituitary gland, acting as a signal to release two distinct hormones into the systemic bloodstream: FSH, follicle-stimulating hormone, and LH, luteinizing hormone.
And where do they go?
These travel all the way down to the gonads, the ovaries or testes, and command them to produce the sex steroids: estrogen, progesterone, or testosterone.
And the female menstrual cycle is driven entirely by the rising and falling tides of these chemicals. The texts break it down into the follicular phase and the luteal phase.
Exactly. In the first half of the cycle, the follicular phase, the pituitary sends out FSH. Just as the name implies, it stimulates a group of ovarian follicles to grow and mature.
And what do those follicles do?
As this dominant follicle grows, it acts as a factory, pumping out increasing amounts of estrogen into the blood. This estrogen travels to the uterus and causes the endometrial lining to proliferate and thicken, preparing a bed for a potential pregnancy.
Now here is where the feedback loop gets so complex. Usually in the body, high hormone levels cause a negative feedback loop.
Right. Just like a thermostat turning off the furnace when the room gets warm. Usually, as estrogen levels rise, it tells the hypothalamus and pituitary, "We have enough. Stop sending FSH." This prevents the ovaries from overstimulating.
But right before ovulation, that negative feedback suddenly reverses. Why?
It is a remarkable threshold effect. When the mature follicle produces a massively high, sustained peak of estrogen for about 48 hours, it alters the receptors in the pituitary. Suddenly, the thermostat flips to a positive feedback loop.
So it causes more hormones to release.
The high estrogen acts as a massive trigger, causing the pituitary to dump its stored reserves of LH into the blood.
The LH surge.
Yes. This massive spike of luteinizing hormone is the exact enzymatic trigger that causes the wall of the mature follicle to physically digest and rupture, exploding the egg out into the fallopian tube. That is ovulation.
And after the egg is gone, we enter the luteal phase.
The ruptured follicle left behind in the ovary transforms into a yellowish structure called the corpus luteum. It becomes a temporary endocrine gland whose sole purpose is to pump out progesterone.
And what does progesterone do?
Progesterone takes that thick uterine lining and makes it secretory, filling it with glycogen and nutrients, perfectly preparing it for a fertilized egg to implant.
And if the egg isn't fertilized?
The corpus luteum has a strict lifespan of about 14 days. If no pregnancy hormone HCG arrives to save it, it shrivels up and dies. Progesterone levels crash to zero.
And then?
Without progesterone to support it, The nutrient-rich uterine lining starves, sloughs off, and menstruation begins, resetting the entire cycle.
It is an incredible, highly orchestrated chemical dance. And the texts emphasize assessing these areas, teaching breast self-exams, noting that the upper outer quadrant extending into the armpit in what's called the tail of Spence is where the vast majority of breast cancers occur.
Due to the high density of glandular tissue there.
They also emphasize preventative screening, like Pap tests, which physically scrape cells from the cervix to look for dysplastic precancerous changes caused by the human papillomavirus, or HPV.
And then, after mapping all of these perfectly balanced systems, we overlay the ultimate unstoppable variable, time. Gerontology.
How aging affects every single system we've just discussed.
And this is vital for clinical judgment because a normal finding in an 85-year-old is often a highly abnormal finding in a 30-year-old. You must adjust your baseline.
Reading this, it seems like aging universally just turns down the dial on the body's efficiency. Decreased estrogen postmenopause removes the protective inhibition on osteoclasts, leading to rapid bone mass loss and osteoporosis.
Decreased GI motility causes chronic constipation. The thyroid gland atrophies, slowing metabolism.
Everything slows down, including the nervous system. Deep tendon reflexes become sluggish. But the most dangerous clinical manifestation of this slowing is something called orthostatic hypotension.
Right. Getting dizzy when you stand up because your blood pressure drops.
But I want to explore the why here. Is it just because the heart muscle itself gets tired and weak, or is there a specific neurological failure happening?
It is deeply neurological and structural. The texts detail that as we age, there are actual morphologic changes, physical alterations in the shape and density of the ganglia in the autonomic nervous system, as well as a downregulation of the baroreceptors in the carotid arteries.
The baroreceptors are the pressure sensors that tell the brain what the blood pressure is.
Exactly. When a young, healthy person goes from lying flat in bed to standing up, gravity instantly pulls a significant portion of their blood volume down into the veins of their legs. Blood return to the heart drops, cardiac output drops, and blood pressure to the brain plummets.
But they don't pass out.
Because their highly sensitive baroreceptors detect the drop instantly and fire a signal to the sympathetic nervous system. In a fraction of a second, the sympathetic nerves release norepinephrine, which clamps down on the smooth muscle in the leg veins, squeezing the blood back up.
While simultaneously telling the heart to beat faster and harder.
The pressure normalizes before the brain even realizes it dropped.
But in an older adult, those pressure sensors are dulled and the electrical wiring is frayed.
Yes. Because of those morphologic changes in the ganglia, the sympathetic nervous system literally slows its response time. The patient stands up, gravity pulls the blood down, but the signal to clamp the vessels is delayed by crucial seconds.
So the brain doesn't get the blood.
The brain goes without adequate perfusion, and the patient experiences severe dizziness, blurred vision, or syncope. They faint.
It's a structural delay in the electrical wiring, causing a mechanical failure in the plumbing. And that is why a massive part of nursing assessment and patient safety involves teaching older adults to change positions in stages.
Right, sit on the edge of the bed for 2 minutes before standing to give their frayed wiring time to catch up.
That is clinical judgment in action. You understand the cellular pathophysiology, and you apply a behavioral intervention to prevent a catastrophic fall.
Okay, we are nearing the end of our dive. We've looked at all the clues on the outside. We've tapped on the chest. We've listened to the murmurs and the gurgling bowels. We've tested the cranial nerves.
But sometimes all of that external, non-invasive data just isn't enough. The detective hits a wall.
And when you hit a wall, you have to look inside. Section 7 of our texts covers deep diagnostics, invasive procedures where we physically enter the body to retrieve tissue, fluid, or direct visual data.
And for the clinician, the focus abruptly shifts from assessment to acute patient safety and post-procedure monitoring.
Right, it's like knocking on a wall to find a stud versus taking a sledgehammer and opening the drywall to actually look at the pipes.
The texts list endoscopic procedures, bronchoscopy to look down into the lungs, colonoscopy for the lower GI tract.
And each comes with specific, severe physiological risks. With a colonoscopy, for example, the text emphasizes the vital importance of the bowel prep using osmotic laxatives.
Why is that so crucial?
If the bowel isn't completely evacuated, the camera cannot visualize the mucosa to find precancerous polyps, rendering the entire invasive procedure worthless.
Plus, during a colonoscopy, they actively pump air into the colon to inflate it so the camera can see, right?
They do. And that artificial hyperinflation stretches the bowel wall. The clinician must monitor closely afterward for sudden, severe, board-like abdominal pain and fever,
Which means what?
which are the hallmark priority findings of a bowel perforation. The camera, or the air pressure, actually poked a hole through the intestine, spilling fecal matter into the sterile peritoneal cavity.
A catastrophic complication. Then there are the fluid and tissue punctures, using large bore needles to pull samples from deep inside the body. Bone marrow aspiration from the iliac crest of the hip. Thoracentesis, where a needle is inserted through the chest wall to drain fluid compressing the lungs.
But there are two highly specific puncture procedures detailed in the texts, where the physics of how the patient lies in bed afterward is literally a matter of life and death. The liver biopsy and the lumbar puncture.
Yes. I was fascinated by the physics of this. Let's start with the liver biopsy. They insert a long needle between the lower right ribs, puncture the liver capsule, and core out a piece of liver tissue to check for cirrhosis or cancer. Why does the angle of their body matter so much when they get back to their room?
You have to understand the anatomy of the liver. It is a highly vascular organ receiving blood from both the hepatic artery and the nutrient-rich portal vein. It is essentially a giant blood-filled sponge.
Okay, a bloody sponge.
Furthermore, the liver is the factory that produces almost all of the body's coagulation factors, the proteins needed to clot blood. Patients needing a liver biopsy often have liver disease, meaning their blood already doesn't clot well.
So you're stabbing a highly vascular sponge in a patient who can't form clots.
Exactly. And because the liver is deep inside the abdominal cavity, you can't just put a gauze pad and some thumb pressure on it like you would a paper cut. It will bleed freely internally.
So how do you stop a hemorrhage you can't reach?
You use the patient's own body weight and gravity as a medical tourniquet. The nursing protocol dictates that immediately after the needle is withdrawn, the patient must be rolled onto their right side, often with a rolled towel placed directly under their right lower rib cage.
And they have to stay there.
They must remain perfectly still in that position for a minimum of 2 to 4 hours.
Oh, because the liver is on the right side of the body?
Precisely. By lying on their right side, the immense weight of their own torso presses the liver tightly against the rigid chest wall and ribs. It physically splints the puncture site, applying intense internal hydrostatic pressure to counteract the bleeding.
And if they move?
If the patient gets uncomfortable and rolls onto their back too soon, that pressure is released, and they could silently hemorrhage to death into their abdomen.
That is brilliant. Using gravity and body weight as a physical tool. Now, what about the lumbar puncture? They insert a needle into the lower spine, usually between the L3 and L4 vertebrae, going deep enough to tap into the subarachnoid space to collect cerebrospinal fluid, or CSF.
Right. They do this to analyze the fluid for white blood cells and meningitis, proteins in multiple sclerosis, or red blood cells indicating a subarachnoid brain hemorrhage.
To get the fluid, the needle must puncture through the dura mater, the tough, leathery outer membrane that encases the spinal cord and seals the fluid in.
And when they pull the needle out, it leaves a microscopic hole in that membrane. I read that the strict rule here is the patient must lie completely flat on their back afterward. Why?
To understand this, you have to picture the brain and spinal cord as a closed hydraulic system. The brain literally floats in a bath of pressurized cerebrospinal fluid inside the skull.
Okay, so it's a closed loop.
If the patient sits up or stands up after a lumbar puncture, gravity pulls the column of fluid downward. Because there is now a hole in the dura in their lower back, the pressure forces the fluid to leak out of the puncture site into the surrounding epidural tissues.
That's bringing a leak in their hydraulic system.
Yes. And as fluid leaks out the bottom, the hydraulic pressure inside the skull drops dramatically. The brain loses its buoyancy. It physically sags downward, pulling and stretching on the highly sensitive meninges and blood vessels anchoring it to the top of the skull.
And that causes pain.
This causes a massive, excruciating, throbbing headache, the classic spinal headache that gets worse when they sit up and better when they lie down.
And if the leak is severe enough and the pressure drops too fast,
it leads to the ultimate neurological nightmare, downward brain herniation. The pressure gradient forces the brainstem down through the foramen magnum, the hole at the base of the skull where the spinal cord exits.
which is fatal.
Compressing the brainstem crushes the respiratory and cardiac centers, which is fatal. So, keeping the patient completely flat for hours ensures the fluid pressure remains equalized horizontally, preventing the brain from sagging while giving the tiny dural puncture hole time to seal itself.
It's all plumbing and physics at that point.
Yeah.
It's the same extreme caution we saw with the cardiac catheterization. They thread a thick catheter up the femoral artery in the groin, all the way into the heart, to look for blockages.
And post-procedure, the primary concern is the integrity of that femoral artery. It is a massive high-pressure vessel.
Yeah.
When they remove the catheter, they apply intense manual pressure to form a clot. But the patient must maintain strict, flat bed rest with that affected leg kept completely, rigidly straight for hours.
Because if they bend their hip,
If they bend their hip, the mechanical flexion of the joint will pop that fresh clot right off the artery wall. Because it's an artery, the blood will pump out under high pressure. They can hemorrhage massive amounts of blood into the retroperitoneal space or their bed in minutes.
the clinician's job is intense vigilance, constantly checking the insertion site for swelling, and constantly checking the pulses in the foot, the dorsalis pedis and posterior tibial pulses, to ensure the artery hasn't formed a massive clot internally that is cutting off blood flow to the leg.
The level of critical thinking required at every single step is staggering. Which brings us to the end of this deep dive. We've gone from the simplest, quietest interactions, shaking a patient's hand, feeling the temperature of their skin, evaluating if they are dressed appropriately for the weather, all the way down into the molecular chemical dance of hormones.
The diffusion of oxygen across microscopic membranes and the raw physics of internal hydraulic pressure. We've decoded the secret language.
It really is a marvel of biological engineering. What we've seen today is that adult health assessment is absolutely not a rote checklist of disconnected parts. It is a highly sensitive, interconnected web.
The skin reflects the efficiency of the lungs. The kidneys dictate the clarity of the brain. A tiny, lentil-sized gland in the neck dictates the electrical voltage of every nerve cell in the face.
The clinician's job, the detective's job, is to read those subtle, peripheral clues, synthesize the subjective story the patient is telling with the cold, hard, objective evidence of the physical exam, and formulate a clinical judgment to restore the balance.
Exactly. True assessment isn't just knowing that a finding is abnormal. It's understanding the exact physiological reason why it is abnormal and knowing what system is going to fail next if you don't intervene.
And it leaves me with this final provocative thought. We've spent this entire time analyzing these texts, learning how medical professionals read these subtle warning lights in other people. But the source material proves how deeply interconnected your own systems are.
It's very true.
A change in the curve of your fingernails could indicate a congenital heart defect. A change in your ability to smell a cup of coffee could mean a neurological tumor. An inability to handle a stressful day at work might be your adrenal glands crying out for help.
It's true. The body is constantly talking, broadcasting its status on a dozen different frequencies.
So my question to you, the listener, is this. What is your own body's baseline? Are you tuned into your own secret language? And what subtle, quiet clues might your own personal engine room or command center be giving you right now that you've been entirely ignoring?
A powerful question to walk away with. Pay attention to the whispers before they become shouts.
Thanks for joining us for this deep dive into the art and science of health assessment. Remember, understanding the mechanics of your own body is the ultimate shortcut to being well-informed. See you next time.